Hi, my name is Amanda Rosa, and my case study was on distal extremity dislocation. My introduction is the patient was a 17-year-old male. Patient had injured his right big toe while playing basketball. Patient stated his right foot went into a hole and he heard a snap. There was a toe x-ray ordered. My interaction was with the patient. The patient came in and asked for his name, date of birth, and what had happened to him. He was unable to stand, so that's why I ended up doing the exam on the wheelchair the whole time, so I had to place the IR on the floor. I had placed a shield on his lap, and as well I put his mom behind the lead wall. Since he was a minor, she had to be in the room. So this is the lead wall that I've used, and as well this is a lead apron I used for the patient. So the first exam was an AP foot. The position is the IR was placed on the floor. The foot was placed flat on the IR. The sphere was angled 10 degrees posteriorly. Technical factors was a 50 kVp and about a 2 MAS. My critique is in the AP image, interphalangeal joint space appears to be closed compared to the post-reduction image where the space is open. You can just see closely here. You can just tell there's a little bit of a difference of the space opening. Next was the AP toe. The position was the same. IR placed on the floor, the foot placed flat on the IR. Collimated to the area of interest, which is the big toe. The only thing different, I did not angle the 10 degrees posteriorly. For the toe, I kept the same technical factors. My critique stays the same as for the AP foot. You can see the interphalangeal joint spaces appear to be closed compared to the post-reduction image. Next is my oblique toe. My positioning was I placed the foot flat on the IR, but then I ended up turning the foot medially 45 degrees. I collimated to the area of interest, which is the big toe. My technical factors stayed the same. My critique did change. In the oblique image, the distal phalanx appears to be dislocated from the proximal phalanx compared to the post-reduction. As you can see, all the anatomy looks to be back aligned as it was before. Next, after that one was my lateral toe. The positioning was the IR was placed flat on the floor, foot placed flat on the IR, lateral medially because it was the big toe. I collimated to the area of interest, which is the big toe. Reason why I did lateral medially is because if I would have done medial lateral, it would have created a lot of OID. So I decided to put the actual toe on the IR. The pinky toes on the IR. The technical factors were the same. My critique is in the lateral image, the distal phalanx appears to be dislocated from the proximal phalanx compared to the post-reduction image. All anatomy is aligned. The only thing I did a little different was I didn't use any tape on his other phalanges due to the patient's anatomy. Instead, I decided to angle it to 5 degrees cephalad to avoid superimposition of his metatarsals. So you can see the dislocation better in the first image. And the last image, I did not bother to angle. I just did a regular lateral toe. And in conclusion, this is the radiologist's report. He decides to say there's no evidence of acute fracture, traumatic malignant, no evidence of radiopaque foreign body, no substantial degenerative change. So pretty much he didn't have any fractures. It was just a dislocation. After the post-reduction, everything was back to normal. And this is my case study.